So, Dr. Dida, we can start.
Okay.
Okay, great. Yeah, go ahead, and then I'll say something too.
Okay, perfect. So hi, I'd like to thank Jenny Galvin for helping us coordinate this webinar. I'd also like to thank APOS for their continued support of pediatric low vision rehabilitation and for educational opportunities like this one. I'd like to welcome everyone to our webinar this evening or afternoon or morning, whatever time it may be from where you're joining us. And our title of the webinar this evening is Pediatric Low Vision, Helping You Help Your Patients. My name is Lauren Dida, and I've had the privilege of serving as chair of the APOS Pediatric Low Vision Rehabilitation Committee. This webinar is brought to you by a tremendous group of individuals, your colleagues from the APOS Pediatric Low Vision Rehabilitation Committee, and you can see our fabulous group of speakers here. These individuals are not only experts in the field of pediatric low vision, but they're also advocates for children with visual impairment. And I'd like to thank all of them for the outstanding work that they're doing to help our patients and our families. At the end of all of our speakers this evening, we'll have a brief Q&A session. Please post your questions in the chat. Finally, if you aren't familiar with our committee and what we do, I'm very happy that you're joining us for this webinar this evening because now is a really great time to learn about us, what the committee does, and get involved. Please consider visiting our APOS webpage through the links that you see here and take advantage of the low vision resources that are made available to you and to your patients. So without any further ado, I'd like to introduce our first speaker for this evening. Jenny, would you like to say anything about the specifics about how that webinar is going to work?
Oh, yes. Yeah, thank you, Dr. Dida. I'm Dr. Jenny Galvin, and on behalf of the Online Media Committee, we're here in the background, and we're really happy to be a co-host, so to speak, with this pediatric low vision webinar. And something that we wanted to let you know in case you can't join us for the entire part, it's going to be on the APOS YouTube afterward. And then please use the Q&A for the questions, as Dr. Dida mentioned. We'll do it at the end of the 6 panelists. Thank you.
Okay. So I'd like to introduce our first speaker, Dr. Linda Lawrence. So this individual is truly and selflessly has devoted her career to pediatric low vision. Dr. Lawrence has a solo private practice in Salina, Kansas, but she's also a consultant for the Kansas State School for the Blind and a volunteer assistant professor for ophthalmology at the University of Kansas School of Medicine. When she's not in Kansas, she's working and collaborating with teams around the world and around the country to improve resources, education, and care to children with low vision. Linda's an outstanding mentor to so many, including myself, and just a really amazing humanitarian. So I'd like to thank Linda for joining us, and her talk this evening will be Etiologies of Pediatric Low Vision.
Okay, thank you very much for that introduction. This is just a wonderful opportunity for us to share all of our knowledge about kids with low vision and really advocate for them. And I wanted to make this talk not quite so dry and just about etiologies, which you can of course Google on iWiki, but to actually talk about some unusual etiologies of pediatric low vision. This is a child from the 1920s in a school for the blind reading Braille. So she wasn't properly assessed, and she's using her vision to read Braille instead of doing proper either low vision intervention with magnification or using Braille properly. So very interesting that etiologies are going to direct your assessments and your intervention. Now, etiologies are so important because not only do we need to understand about the disease, but the functional consequences of those changes. And we often think about function of the disease entity, the organs that is diseased, without thinking about the function of the whole person. In a child or person with low vision, we're always going to have to think about that person. We need to correctly identify the cause of a disease to identify the proper course of treatment. So the etiologies of low vision and blindness in children are many and varied, and we want to remember that everything is a spectrum. The disease does not totally determine destiny for a child. So just because they have ocular albinism or ROP or RP or whatever they might have, they're still going to be unique. We like to separate etiologies into prenatal, perinatal, postnatal, and especially, are they progressive or stationary? Now we got to figure out, are they just ocular? Are they just brain-based? Do they have other ocular, cerebral, or systemic involvement? What about uncorrected refractive error? This is a big part of our low vision internationally. We can have primary organ structure failure in causes of congenital blindness. But remember that trauma, tumor, infection, toxin, genetic, metabolic can affect any part, any layer of the retina, of the eye, of the brain, and cause unique low vision. Children with low vision will often have comorbidities, ocular, systemic. They may be on medication that affects their use of vision. So remember that every child is unique, even if they have the same diagnosis and even if they have the same visual acuity, their use of vision is going to be different. When there's a delay of visual milestones, which we should know and we should measure, we have to figure out, is it the eyeball, is it the visual function, or is it the way the child is using their vision, or is it the functional vision? And this is the same whether it's ocular or CVI, or if the child has cognitive or intellectual disabilities and we can't measure their vision or we don't understand what they're trying to tell us. Also, a child with motor challenges, like in cerebral palsy, may not be able to show us what they can see. And a child, for example, with autism spectrum disorder may have communication difficulties and not be able to, again, make us understand what they see. Now, etiologies of visual impairment are not well documented. We have very poor databases, unfortunately. The one on the right here is babies count. It is now 10 years old. And it was a volunteer registry for teachers of the visually impaired from birth to 3 on newly diagnosed conditions that were low vision or blindness. Okay, so this is birth to 3. You can see in this pie chart, CVI is about 25%, ROP 12, ONH 11. Now, that's United States. The one on the left is from Aravind Madurai, put together by Dr. Vijay Lakshmi, and it shows very similar findings. CVI 26%, ROP 13, retina 15. You know, we have, as medical care gets better and better across the globe, we're seeing changing etiologies of low vision and blindness. So we have to continuously keep up. I would encourage all of you all who are in different countries to get a database for your country. Start looking at those causes, because those causes are that you know will then direct your assessment and intervention materials. In the US, we have what's called the Federal Quota. Now, what that is you know, the eye care provider has the key to the patient getting services. And what we need to do is decide, does this child meet the definition of blindness, which is 2200 or less, or 20-degree field, or do they function at the definition of blindness, which is often the case in CVI, or does the visual impairment interfere with their access to education? And it's very important that you talk about this in your letters and in your reports. I want to show you 6 cases of why etiology is important. Let's talk a little bit about refractive, uncorrected refractive errors, structural causes, ocular motor causes, which is something we don't think often about, CVI, and then CVI and ocular problems that coexist. In our original training about CVI, we were told that the eye was normal, but now we know that's not true. So this first case I'm going to talk about is uncorrected refractive error. This boy in the lower left was a child I saw in Brazil. He was had cerebral palsy, nonverbal. He had a what we would consider probably normal for age hyperopia of a +3. He had never made eye contact with his mother. That's the only thing she wanted. I had a pair of +3 glasses. That was his refraction. We put it on him. He had very poor accommodation, and with a simple +3, he was able to make eye contact with his mother. So don't negate low prescriptions in children with multiple disabilities. They're not going to be able to tell us, oh, I see better or not. You have to do your assessment and you have to think about it. You have to think about each child's unique need. Don't try and fit them into a chart of what's normal. These kids are not typical. We should not use typical charts in outlining their interventions and assessments. They need dynamic retinoscopy. Many of our kids with low vision have difficulty with accommodation. This little girl here, we put in trial frames. We measured her dynamic retinoscopy or accommodation, and that helped us determine whether to give her the glasses, give her additional plus. And this little girl here with Down syndrome had very significant myopia. And when we put the trial frames on her, she just looked at her hands forever. It was just the most amazing thing. So trial frames are good. Think outside of the box with your refractions. Also think outside of the box on a child like this who has blepharophimosis syndrome and DeGeorge syndrome. She lives in Lima on the top of the sandhill, and she was thought to be severely visually impaired. However, if you look at her lid folds, you can see she has almost slit-like eyes, severe ptosis, poor levator function. Unfortunately, surgery not available yet. We're working on that. The rest of her eye exam was unremarkable. Now, all we had to do, she's a little tiny girl. You can see her here cooking in the kitchen with her mother. We put her up on a stool so she could use her vision appropriately. And that's what we did in the school place too. So think outside of the box. Sometimes there's simple interventions for low vision, and also things that you might not typically think would cause low vision, like ptosis. These 3 boys from Nigeria all had great cataract surgery. They had congenital cataracts, had great surgery, posterior chamber lens implants, and they were still severely visually impaired. Why? Improper follow-up. They didn't have proper refraction. They didn't have bifocals to help with accommodation. Remember, when you remove the cataract, there goes the accommodation. They needed follow-up for glaucoma, treatment for amblyopia. They needed posterior capsulotomies. So you can have a perfect surgery, very good outcome, surgical outcome, and still have a child with low vision. So remember, follow-up is so important. It's another case, these 2 young women that are patients of mine in Lima for over 14 years, they had a history of congenital cataracts, surgical aphakia, had some pigment disruption in the retina, hearing impairment, and cognitive disabilities. They were diagnosed with congenital rubella when I saw them. They were working, bringing money home to their family. I followed them routinely, and 10 years out, I started saying, the pigment's changing in the retina. There's more pigmentary changes. That caused us to go ahead and get an ERG. We found findings consistent with retinitis pigmentosa. So this is so important to remember, to follow these kids and always be thinking about what your diagnosis is. Now, this totally changed these girls' life, because now we know they have a progressive condition and they're going to need additional assistance to keep their jobs that's helping support their family. This is a simulation of one of the girls' vision. This is my son, and we made a visual field, a little pinhole here, and this simulates 2200 vision. This is my copier, of course. And sometimes simulation is so helpful for the family, for teachers, for the parents, and for the other siblings to really understand what's going on with this child's vision. We actually made a video of how she sees and how she climbs up 100 steps up the mountain every day to her home. Now, ocular motor conditions are something, again, we don't typically think about as causing low vision, but strabismus, especially esotropia with cross fixation, can cause limitation of midline, gaze, severe developmental delays. And this is one article that came out of our studies on the children with congenital Zika syndrome in Brazil. Liana Ventura is the lead there, which showed that the strabismus surgery actually improved not only ocular alignment, but expanded the visual field, and of course, improved the social emotional connections with the parent. And if you think of this little girl here with the cross fixation, if you were looking straight ahead and your eyes were straight and your fields were normal and everything's working good, you're going to have this great field of vision. If you're a cross fixator, even if you're monofixating, so you're using one eye at a time, your nose gets in the way, your peripheral field comes over to the midline. And so you're using your peripheral vision for the midline viewing. You can't see anything in the midline. You can't reach for your toys. You can't see your mom's face. And then you can say, well, they monofixate. Well, unless they're bringing that eye to midline, their nose is going to obstruct a large percentage of your visual field. It's something we don't often think about. In cases of cortical and cerebral visual impairment, this is a boy with cerebral palsy, and he had successful strabismus surgery that we felt would treat his clumsiness. He had an alternating exotropia. However, despite good surgery, he still had clumsiness. We did eye gaze, which we use a lot here in Kansas. We have them look at a eye tracker, and we have them play a video game. And if you see here on this custard pie, this is a heat map that shows where he was playing the game. This whole lower field was missing. So this gave us a snapshot of his visual acuity, and we were able to better address his needs. Again, here's ocular disease and CVI, a girl with ROP, stage 5 in the right, NLP, high myopia, had LASIK that really helped her from a -16 to -4. Later on, we were able to do a visual field and also found a hemianopia. So she had laser scars causing peripheral changes as well as a hemianopia. Then we found with OCT that she had foveal hypoplasia. We've been addressing all of these things. This is a picture of how big she was when she was discharged from the nursery, and she's now getting ready to go to college. So, diagnosis does not determine destinies. So think outside of the box, and children with low vision, be their advocate. They need you. And thank you very much. Feel free to contact me.
Thank you, Linda. Our next speaker is Dr. Judy Garland. Dr. Garland's an assistant chair of the Department of Ophthalmology of Bronx Care Healthcare System. She's had many years of experience in low vision, working with the Lighthouse for the Blind, as well as launching a low vision service at New York Eye and Ear Infirmary. Judy's been on the Pediatric Low Vision Rehabilitation Committee for several years. We love her enthusiasm, and she'll be talking to us tonight about the evaluation of a child with low vision. Thank you, Judy.
Mute myself and let's get started. First of all, I want to thank all the organizers. Can everyone see my screen now?
Yes.
Okay, terrific, thanks. And I want to add to some of the things that Linda just said as well. In addition to being able to see a child's, why am I not going forward here, folks? Great. A child's life should be full of fun, and keep that in mind while you conduct your exam and while you evaluate these children who have visual limitations. Remember to look for pearls and jelly beans when you're looking at these kids. And as Linda said before, think outside the box. Published statistics from the World Health Organization show that up to 3/4 of children who are classified as legally blind and who are attending the schools for the visually impaired have conditions that, had they been diagnosed or treated earlier, might have really good functional vision. Keep that in mind. So how does this relate to us? There may be less time to do your hands-on examination than I have to deliver this talk. Become familiar with Dr. Leah Hyvarinen's work. She has published an awful lot about detailed statistics, and detailed specifics of the examination of these children. The iWiki site, as Linda was referring to earlier, has a very comprehensive pediatric low vision section, and it's recently been reviewed and updated. There are new books and videos available on a regular basis as well nowadays. So here we are evaluating the child. Who are we evaluating? We're evaluating the child, the family, other caregivers, and that includes you. We have to consider the visual needs as well as the visual abilities of each child, and we have to take into account the timing of the exam and the timing in the life of the child, as well as the circumstances of the family. Circumstances involve a where. A child's real life isn't in your office or having an eye examination, it's in their surroundings on a regular day-to-day basis. Your exam is going to involve standard examination techniques, but many of these examination techniques are going to have to be modified in order to get the useful information that you're seeking. And the new technology that's available today, as well as the incorporation of telehealth, is very important, and other speakers are going to be addressing this. Now, don't approach the exam with preconceived expectations. Listen to everyone involved. With access to the online health records, you can actually do your homework way before the appointment itself. You can review test results, you can communicate with other caregivers. The examination itself has to be done quickly, very, very often. Be prepared to move around. If the child's not able to walk, you may have a variety of obstacles to maneuver around. The child who Linda showed before, who's autistic, may be running around the room and you're going to have to chase them, or at least engage them in some way to look at you. This may be a very new and or a frightening experience for the child or for the parent, and it may impact the cooperation of either or both. Be familiar with the developmental milestones that are normal, but don't be tied to that familiarity. Visually impaired children may not experience the same physical development as a normally sighted child. For example, a baby who's unable to fixate or follow may not regularly turn their head. That in turn is going to impact the development of the neck and the neck shoulder girdle, which that may not develop on time as expected. If that's delayed, the child may not turn over as expected, and a whole cascade will be set in motion. If an infant cannot see or can't respond to the details of a parent's face, the normal bonding process will also be interrupted. One of the things I tell parents, especially the moms, is to wear a lipstick of a contrasting color to their skin. It helps the child fixate better on the face and experience the facial expressions. Be familiar with how to do a red reflex test, a Bruckner test, both on a binocular and a monocular red reflex to get important information. The test may be familiar to lots of people because nowadays there are instructional videos and other informative texts that are readily available on the internet, and they're available to the public. Become familiar with the use of your direct ophthalmoscope. You can compare pupil size, pupil shape, quality, reactivity, possibly even get an idea of convergence and or accommodative responses. You might be able to even see iris transillumination. You can access fixation ability, and in some cases, you may even be able to check corneal birefringence. And in most cases, you can do this from across the room, or certainly without approaching the child and being threatening in any way. With corneal birefringence, you may see a pattern like this through the dust cover or an accessory filter of a direct ophthalmoscope. And this will certainly give you an idea of corneal irregularities. Now, what do I mean by evaluation? What do we mean by evaluation? By evaluation, we're looking at fixation, some kind of acuity, responses to light and dark and contrast in general, to ocular movement, to an impression of visual fields, and finally to the examination of the eye itself. As Linda was referring to, there are a lot of inconsistencies around in measurements of visual acuity. Most available tests that are used in screenings are not accurate measurements of vision, and they may be unreliable or misleading. Evidence-based tests are available, and they should be used whenever possible. Now, visual field testing, it's usually done by confrontation of some sort. It can be limited to looking for a baby's response to light, or a blink reflex of an infant, or detecting lid or eye movements when trying to elicit OKN. Do what you can to engage the child in confrontation fields. The older children can be bribed with all kinds of stickers that are used as both fixation targets and then as rewards. Remember to choose a fixation target also that's got enough contrast that the child can see. For example, don't use white against white. Color matters too, remembering that yellow fields are the largest fields. A child may respond to a yellow target better than to a smaller green one. And remember also that movement may reveal an area of a visual field that might otherwise be missed. Dr. Hyvarinen has developed many tests to evaluate contrast sensitivity, and these can be used to evaluate children with visual limitations, children and adults with visual limitations, as well as fully sighted children. A slit lamp exam should at least be attempted in order to evaluate the anterior segment. Sometimes you may even be able to measure intraocular pressure. You may not be able to get the child positioned calmly. However, do try. Don't give up. You may have to do this. It can work. Other speakers are going to be talking about refraction, new technology, and telehealth, but I'm going to take a prerogative to add a few comments in advance of that talk. Fundus examination may be easier to do by learning how to use smartphone videos of the retina. Learn how to do this technique. There's an excellent AAO instructional video available. Refraction is extraordinarily important. It's mandatory. Don't forget to check the vision though, both before and after dilation. With some central opacities, such as some congenital nuclear cataracts, vision may actually improve its dilation. I have older people whom I've seen since childhood, for one reason or another, didn't have their cataracts done. And whenever they want to go out driving, they dilate their pupils and their vision improves to 20/30. It's remarkable. Remember that babies nowadays can wear glasses. Remember that visual function doesn't necessarily equate with Snellen acuity. Don't be tied to that. Telehealth visits can also be an important part of your follow-up examination, and it'll give you an idea and feedback as to whether or not you've been successful with your initial evaluation. In summary, keep this in mind. Don't jump to conclusions. So how many jelly beans do you see here? Remember, trust yourself. Don't be afraid to ask semi-leading questions to get information. And most importantly, listen. It's better to over-evaluate than under-evaluate. Keep an open, non-judgmental mind when you approach the exam. That's why bullet 5 is empty. Now here's the picture again. It's in a new light. How many people first saw all 12 jelly beans when we first started talking about 10 minutes ago? So I just want to say, let's improve the WHO statistics. Thanks for listening.
Thank you so much, Judy. I love the flying baby.
It works.
Our next speaker is Dr. Narajan Pere. Dr. Pere is a consultant ophthalmologist and pediatric and neuro-ophthalmology specialist. He's currently the head of Liberia Eye Center at LV Prasad Eye Institute and affiliated with John F. Kennedy Medical Center in Monrovia, Liberia. Narajan has a special interest in pediatric cataract, CVI, as well as early intervention for children with visual impairment. I really appreciate him joining us because for him, it's the middle of the night. and he's doing great. He'll be speaking to us on the approach to parents of a child with low vision. Thank you so much, Narajan.
Good morning and good evening once again, everyone. Can you all hear me?
Yes.
Yeah, and the slides are visible?
Yes, looks great.
Okay. So at the outset, I would like to thank the APOS organizing committee for organizing this interesting webinar and making me a part of it. The topic given to me is approach to parents of a child with low vision. The objective of this presentation is to share some ideas that we have been using over the years to empower the parents to help their child with low vision. So we start with disclosing the situation to the parents. Now we have discovered a condition wherein we cannot help more with any medical or surgical intervention, but the child has to go for low vision rehabilitation service. So how to disclose the situation? There are a lot of ways. We all do in our own ways. What we have found useful is we all come across these situations at some point in life, and the way we would like a bad news to be conveyed to us, probably we should follow the same for our patients too. And we should understand that whenever we pass on such a news to the family, they go through the stages of grief, which starts with a denial, then anger, bargaining, depression, and acceptance. So different people go through these stages at different pace, and unless they reach the stage of acceptance, they are not really going to receive the advice that we are going to give them. So if we see that people are at one of these stages, we should be friendly and patient and keep giving them that support and information that is needed at that stage. One of our initial conversations, they help to create a proper background. And what we say during those initial visits or the first visit goes a long way in the way that the parents look at their own child and whatever else you are going to do with the child. One of the things that we have found useful is talk about the strengths. No matter how serious the problem is, there is always something good about the child that we can talk. So whenever we focus on such strengths of the child, the family sees some hope in us. Because all these days they have always heard what the child cannot do. Oh, these are the people who talk about what the child can do. So probably it makes sense to follow with these people. Talk about the services available. Many a times we ourselves are not informed enough about what can be done about the children. So if there is something that is not that we cannot fix by medical or surgical means, we should look out for what can be done for the children in the area where we live. Many a times a lot is available. Each of the disabilities that we see in the child, there is a complete science. There are professions which are trained in dealing with those disabilities. So we need to educate ourselves about what all services are available for those children in the area where we work. Now, though the topic is labeled as approach to parent, what we have found is that we need to approach parent and child hand in hand, both of them together. And the assessment intervention model that we follow is the assessment should have a very clear purpose, why we are doing an assessment. And we generally do not go for assessment which are just meant for research or laboratory purpose, but we go for assessments which have a real life meaning to them. This assessment should be done in presence of the parent, explaining them the purpose, the procedure, and also the outcome in a language that they would understand. And the outcome of this assessment should be linked to an intervention. If the assessment cannot link to an intervention, that assessment actually is more of a scientific jargon rather than any useful help for the child. And this intervention should be such that can become a part of the routine of the child's life. Then only the vision can become a phenomenon that happens throughout the day. Otherwise, it just becomes a few sessions during the day, which may not be very optimal. Basically, what we need to do is envision the parents, how the child sees. Now, though we have specialized in the science of vision, the best people who know about child's vision is parents themselves, because they spend the whole time with the child. The only issue is that they know it, but they don't know how to articulate it. Or they may have observed those things, but they are not very sure, is it because of vision? So we just need to help them to understand it and, importantly, apply it for the day-to-day activities of the child. Now, taking an example of this preferential looking test, we all use this test. Now, suppose we have found that a child's visual acuity is 4 CPD, or by teller acuity cards, maybe say it is 2200. Now, when we convey this information to the child, does it make any sense to the parents? But if we compare the parents' thickness of fingers with the line thickness that is found with the line thickness of the Lia paddle or the teller acuity card that the child could look at, then they can really envision as to what is required for a child to appreciate something. So if the child could look at this paddle, we can say that the child needs a line thickness of this size. The separation between the lines need to be this much, and this much contrast, this much simplicity, and this kind of a background is required for the child to look at something. Now, how can we translate this information into intervention and part of routine? So whenever parents look for a toy for the child, yes, this particular doll looks very adorable, but the details are such that they do not fall into the limits of this kind of visual acuity. And that is why this kind of a toy, which is so simple, and it conforms to the line thickness that we found, the line separation, the simplicity, the background, the contrast, everything is such that the toy is now visually accessible to the child. Similarly, the feeding bottle, which is otherwise a transparent plastic bottle, not visible, we can make it visible by attaching this shiny tape, again conforming to this line thickness with the separation, and then giving it a background which is simple and contrasting. Again, we add milk in it, which further enhances the contrast. There is a movement of the milk, there's the smell of the milk. So the feeding experience, which was more of a taste or smell-based experience, now becomes more of a visual and a holistic kind of experience by this kind of intervention, which was based on the teller acuity or the Lia paddle that we assessed. Similarly, different objects that are used in child's routines, they can be selected in the same way. The way we serve food, the kind of background that we use, the separation between the food materials, everything can be tailored accordingly. For a little grown-up child, suppose we have found that the visual acuity is say 20 by 125. Again, even if you explain to the parents that what a normal person sees from a distance of 125 feet, the child needs to come to 20 feet to see it. It's very difficult for them to translate into an information that they can use. One simple way that we have found useful is to put trial lenses in a trial frame till they can see the 21-25 line barely. So probably this is the kind of acuity that the child may have. So we make the parents walk around with that trial frame and try to really understand what is the kind of blur that the child is experiencing. We have also taken pictures for different visual acuities by using a method in different surroundings. Like for this child with 21-25 vision, if the child is in a surrounding where there is high contrast and there is good illumination, the child can still make out a lot of things. But if the surrounding is not well illuminated, child can miss several details. He cannot recognize people, and finer details like the details of the flowers and leaves in the park would be missed. These are two very useful websites that give animations for different situations for different visual acuities, and that's very useful. Coming to visual field, like we have suppose tested the child's visual field by this modified confrontation method using a puppet faces, and we found that child is unable to look at the target which is shown on the inferior side. Now, how does this make sense to the parent? We can advise the parents to walk with a card under their nose and the experience what it really means by having a lower field impairment. When this child is being fed, it is preferable to introduce the food from the upper side, because as you see here, when you put the spoon on the lower side, the child thinks as if the food has disappeared and starts crying. So this has an implication on how would you introduce a new thing to the child, and then we can again use this information to stimulate the field which is not being used. So that becomes a part of the routine. When such a child starts walking, it would be important to use a toy like this, which would take care of the unseen obstacles on the way, and the child doesn't hurt itself and doesn't lose the confidence while walking. Now, this child has a right parietal occipital infarct, and on again visual field testing, we found that the child is grossly inattentive to things which are presented on the left side, no matter what you do and how long you hold it over there, but quite attentive to things on the right side. Now, such a child, if suppose she is made to sit in a classroom on the right side and the teacher is standing on the left, she's not going to see the teacher. She is not going to see half of the board. So she should be made to sit somewhere on this side of the classroom. And this is what needs to be told to the parents. Similarly, if a child has a constricted visual field, the child has to use several scanning strategies. If the child's contrast sensitivity is found to be poor, then this kind of enhancing the facial contrast would help the child to look at some of the facial features, and this kind of animation helps them understand that even if this picture is quite blurred, because we have enhanced the facial features with the makeup, child can see something on the face which will help the child to look at the face. Simultaneous nausea is a very common issue among many children with CVI, and we show them this kind of a puzzle. Can you really read this? It's hard for most of them. And the reason is that all these letters are so close to each other that it's hard to make them out one from the other. So there is need for some distance. This is for a person with normal, the so-called normal vision. But a child with CVI, even this spacing may be inadequate for them and further spacing would be required. And then this concept gets into various things that they do in their day-to-day routines. So in summary, we need to set the ground with appropriate counseling, because that goes a long way in how they look at whatever we do. And we need to empower the parents with information about how the child sees in simple language, in practical terms, and train how to use that information to translate into the daily activity, daily routines of the child. Thank you.
Thank you, Narajan. Excellent resources for our families and parents. Our next speaker is Dr. Melinda Chang. Dr. Chang is an assistant professor of ophthalmology at the Children's Hospital, Los Angeles, and USC Roski Eye Institute at the Keck School of Medicine. Melinda is an expert in both pediatric ophthalmology and neuro-ophthalmology, being dual fellowship trained in both areas. She has a special interest in pediatric CVI and has really quite quickly become an expert in this field. The title of her talk is Cortical Cerebral Visual Impairment and the Pediatric Ophthalmologist. Thanks, Melinda.
Thanks, Lauren. Thanks, everyone, for being here as well to listen to my talk. I'm so excited to tell you about this topic, which is very near and dear to my heart. Let's see. Okay, so these are my financial disclosures. This is just a brief outline. We only have 10 minutes, so I'm not going to go over this in detail. So just background, and we already heard from some of our speakers that CVI is the most common cause of visual impairment in children in developed countries like the US, UK, and Australia and New Zealand. We don't have a lot of great epidemiologic data here in the US, but CVI is the leading cause of visual impairment among kids in schools for the blind in the US. And it's increasing in prevalence in developing countries such as India, and Narajan is here and he could tell you guys more about that. Some recent data suggests that CVI may be underdiagnosed in special needs children who can't really tell us if they have problems with their vision. A recent study found that about 30% of kids in the UK who are receiving extra educational help, which I presume is sort of like special ed in the US, or who screened positive on the Strengths and Difficulties questionnaire, were diagnosed with CVI. So it's a very common problem. It's also a very heterogeneous disorder. So anything that causes damage to the brain, the visual pathways in the brain, can lead to CVI. Most commonly in most series is CVI is caused by hypoxic ischemic encephalopathy, especially periventricular malacia in the setting of prematurity. CVI can also be commonly caused by seizures, hydrocephalus, trauma, especially unfortunately non-accidental trauma, infections, structural brain abnormalities like schizencephaly, in utero drug exposure, And genetic disorders have been increasingly recognized as the cause of CVI. And many kids with CVI actually have more than one risk factor or etiology of CVI. So in this talk, we'll be talking about what the role of the pediatric ophthalmologist is in caring for kids with CVI. And I submit to you that there are three major roles. The first is diagnosis and workup. The second one is management of ocular comorbidities. And the third is referral for services. And we'll go through each of these here in some detail. So the first step is diagnosis, and to be able to diagnose CVI, we have to know what is the definition of CVI. And interestingly, this is actually kind of controversial in the literature. So the definition that we mainly use here at CHLA, which is the traditional definition, which is a little bit more stringent, is that CVI is defined as subnormal visual acuity or visual field loss caused by damage to the postgeniculate visual pathways in the brain. Kids with CVI either have no intraocular pathology or vision loss that's greater than expected for the degree of ocular pathology. So for example, many kids with CVI have optic atrophy, but the optic atrophy is mild in comparison to the profound level of visual impairment that they have. A more recent or modern definition of CVI is shown here from this article that was published in 2018, which is that CVI is a verifiable visual dysfunction which cannot be attributed to disorders of the anterior visual pathways or any potentially co-occurring ocular impairment. So traditionally in pure CVI, meaning CVI without any ocular comorbidities, the pupils are normal, there's normal ocular ductions, there's no nystagmus, and the optic nerves and retina are normal. But in practice, most of our patients have some ocular comorbidities, so many of them have optic atrophy, nystagmus, strabismus, and refractive errors. In terms of the characteristics of CVI, it's interesting because we believe that there are many characteristics of CVI that are different from kids who have ocular causes of visual impairment like cataracts, glaucoma, or ROP. The first one being that there is a lot of variability or fluctuation of their vision. Parents report that vision is worse when they're in like a crowded or noisy or unfamiliar environment, or if they're sick or tired. There's also a very characteristic crowding effect, as demonstrated here. A child with CVI sees much better when an object is on a plain background versus on a patterned background. Of course, for anyone, it's harder to see this rabbit on that patterned background on top, but a child with CVI might not be able to see it at all. Color vision is thought to be relatively spared due to the bilateral representation of color vision. And often kids with CVI have a favorite color, and interestingly, it's frequently either red or yellow. Contrast sensitivity is frequently reduced, and sort of paradoxically, there may be a reliance on motion to be able to see. So parents may say that kids don't notice an object until it's moving, or they may have a motion processing deficit. And this has been shown in some recent studies that it may be a problem with higher order motion processing. For example, patients may have like a problem with global motion processing. Patients may also have increased saccadic latency or increased time for visual response. This is very characteristic of kids with CVI. And then they may either like to stare at lights, which is more common, or paradoxically, they may have photophobia. So when I diagnose a child with CVI, almost always they come in with an MRI scan, but if they don't have an MRI scan, I do get one right away. You can find things such as hydrocephalus or schizencephaly or abnormalities of the optic radiations that's shown here, which could be the cause of CVI. And it's important to know about these things because some of them, like hydrocephalus, are treatable. Electrophysiology has also been used to assess vision in some kids with CVI, either VEP, visual evoked potentials, or sweep VEP. And sweep VEP was first described in kids with CVI by Dr. Good back in 2001. It's mostly used on a research basis to sort of quantify the level of visual impairment because we don't really need VEP to make the diagnosis of CVI. Many families with CVI are seeking a type of test called functional vision assessment. The most commonly used functional vision test now for CVI is called the CVI range, which was developed by Christine Ridlin-Lancey. But I know that Perkins is also developing this type of test as well. In essence, in a functional vision assessment, a trained examiner, like a teacher for the visually impaired, will try to determine how well a child can use their vision in everyday tasks. And they use things like a light box or like these complexity pegs shown here to see how kids can function with their vision. And then finally, I do order genetic testing in a subset of kids with CVI if they have other systemic manifestations that make me suspicious there's an underlying genetic problem, like if they have dysmorphic features or microcephaly. Okay, the next goal of a pediatric ophthalmologist taking care of children with CVI is to manage their ocular comorbidities. And this is sort of the bread and butter of pediatric ophthalmology. We're all pretty good at this. And there's not a lot of differences when taking care of kids with CVI versus other kids with these problems, but I'm just going to mention a few of the differences. The first one is refractive correction. So obviously we normally prescribe glasses to kids who have a significant refractive error. And I do the same for kids with CVI. Although when their vision is NLP or LP, I typically tell the parents it's not likely that the glasses are they're going to be able to really use the glasses or benefit from the glasses. But if the parents really want to try glasses, I don't withhold it from them. Amblyopia, if you get to the point where you can actually tell that there's a fixation difference between the two eyes in a child with CVI, that's actually a good sign. And you would treat amblyopia the same way in kids with CVI as you would with other kids. And finally, strabismus, as we talked about, is quite common in kids with CVI. My partner, Dr. Mark Borchard, actually a few years ago reviewed the cases of children with CVI who underwent strabismus surgery here at CHLA. Interestingly, he found that there were some kids, about 16%, who had spontaneous resolution of strabismus. And we see this more commonly in kids who have improvement of their vision. So for example, a child with a constant XT, when their vision improves, sometimes they can convert to an intermittent XT with good control, and they may not actually require surgery. Of the patients who underwent surgery, in this paper, they found that 56% of them reached what they considered to be a good outcome, so less than 10 prism diopters of a horizontal deviation after surgery. 28% had a acceptable outcome, and 16% had a poor outcome. And they looked at factors that were associated with poor outcome after strabismus surgery, and they didn't find any that were significant. They thought that the level of vision may contribute. So if their visual acuity was still very poor when they underwent surgery, there was a tendency for them to have more recurrence of their strabismus. So the next step for a pediatric ophthalmologist in taking care of a child with CVI is to refer them for services. So of course, they should undergo low vision services, and depending on what state you're in, they may go to the regional center or have vision services through school. They also most likely will need orientation and mobility training. Many of them will need to see a pediatric neurologist and a host of other medical professionals to take care of them. And then finally, we don't want to forget about the rest of their problems. Neurologic difficulties, so PT, OT, and speech therapy are important. And I think that Lauren had put up at the beginning of this talk a QR code for the resources that we have on the APOS website for low vision. And so that's something that may be useful for you guys to check out too, because there's a very comprehensive list there. So the silver lining is that the vision does tend to improve in children with CVI. There is quite a bit of variability in the literature, but it seems that vision does improve for the majority of children. It doesn't normalize in most cases, and it is a slow process. It takes years, but there is typically a gradual improvement over time. We don't really know exactly what factors are the best prognostic factors. There is some debate in literature, but it seems that control of the underlying neurologic problem is important. So if they have seizures or if they have hydrocephalus, it's important to control that to give them the best chance for their vision to improve. The other silver lining is that there are people now doing research on CVI, including myself and Linda doing eye tracking research to help us better understand if we can develop a quantitative method for assessing the visual acuity so that we can do clinical trials of the various types of therapies that have been suggested for this disorder. So just in conclusion, when you see a child with CVI, you want to remember to most importantly diagnose them and to make sure they have the appropriate workup. Also manage their ocular comorbidities, and finally refer them for the appropriate services. I think we have a question and answer session at the end, but I'll be happy to answer any questions that come up as well by email. Thank you.
Thank you, Melinda. Excellent talk. Now we're going to shift gears a bit and talk about the rehabilitation side of low vision. Our next speaker is Dr. Margaret Reynolds. Dr. Reynolds is an assistant professor in the Department of Ophthalmology and Visual Sciences at Washington University in St. Louis. She has both clinical interest in children with low vision, as well as a research interest in low vision and interventions for affected children. Her talk is entitled Evidence-Based Low Vision Rehabilitation. Thank you, Margaret.
Great. Thank you very much for having me here today. I appreciate being here. I'll be talking about evidence-based low vision rehabilitation. I've certainly been enjoying everyone else's talks. So, and we'll get started here. So I have no conflicts of interest. And a brief outline, we'll talk about the difficulties that low vision children experience, the reason why they need rehabilitation. We'll talk about the team, the research, devices, and some new technologies. So children have unique challenges compared to adults, and we'll go through each of these briefly. So children have who have low vision have a lack of a visual component to inform their tactile, motor, and auditory input as they're growing and developing. And this type of problem can lead to repetitive or stereotypical behaviors because they often have decreased body awareness. These children can also have decreased social participation. Because they can't see very well, they're unable to pick up on or mimic nonverbal cues. And in social situations, they can therefore appear disinterested, and they can have reduced sustained social interactions for this reason. Next, motor development can be delayed in these children. When they're babies, they have this inhibition to move due to fear, anxiety of the unknown. For instance, infants who have low vision are less likely to lift their heads during tummy time. And so this impacts them by causing a delay in crawling or walking for more than 6 months. And they similarly have decreased manual skills. Next, self-concept. These children with low vision tend to wait for stimuli to come to them rather than explore their own environment. So this encourages passivity and an overdependence on others, also called learned helplessness. And then play, they have a lack of incidental learning, which affects their ability to pretend play. And they also have exploratory or sensory seeking behaviors that can persist, such as mouthing, waving, or shaking. And finally, all these things kind of gang up on them to affect their activities of daily living. So they often have decreased participation in routines, just due to lack of incidental learning, learned helplessness, and decreased gross and fine motor skills. And so for all these reasons, they require rehabilitation. And we're going to go through kind of the evidence base behind this. But first, let's talk about the team. So there's certified low vision therapists, and there's certified vision rehabilitation therapists. The low vision therapists tend to work with optical devices, non-optical devices, and assisted technology, and they help determine the need for environmental modifications in the home or school for these patients. Versus the rehabilitation therapists, they teach adaptive, independent living skills in these patients' homes. Then there's the certified orientation and mobility specialists. You've heard about them already today, but their goal is to get each of these children traveling independently at home and in their community. So they teach white cane training, electronic travel devices, and work with mobility. Very important, the teachers for the visually impaired. These are the teachers who work one-on-one with our children. They provide direct instruction and modification of the educational curriculum. They complete functional visual assessments for each of these children and determine the educational consequences of the low vision that these children have. And they're on the team that prepares IEPs and 504 plans. And then finally, we have our occupational therapists who help teach children and their family strategies to improve their ability to be successful at home and school and in the community. For instance, they support the development of pre-braille skills in conjunction with teachers for the visually impaired. So they teach finger isolation, for instance, body awareness, spatial awareness, and tactile discrimination. They also teach mobilization strategies. They work with activities of daily living, help these kids learn to dress, brush their teeth. They teach fine motor strategies, particularly focusing on writing ability as one example, and social skill development, many other things that I didn't include here. Now we're going to talk about the evidence behind what all of these folks do. The reported success rate of low vision rehabilitation adults have typically ranged from 23 to 97%, which obviously 97% is great. Fortunately, there's very little evidence for low vision rehabilitation outcomes in children. The best evidence that exists tends to relate to reading ability and the use of low vision devices. The outcome measures that are typically reviewed in these studies, we're going to look at the main ones. So first, activities of daily living. So this is a study that used low vision devices, educational guidance and counseling, and use of some of the team members that we discussed to help with children with their activities of daily living. They used the LV Prasad functional vision questionnaire and found that with their interventions, there was improvement post low vision rehabilitation. Also a little bit of data with mobility. So there's a randomized control trial with children in a training group versus a home control group. The intervention was a training program that included balance, coordination, strength training, visual motor control, and figure dexterity. And this study found that there was significant difference between the training and the control group. Next, breeding. This was a very small study. As we kind of discussed, there's not necessarily a ton of data in all these areas, but for patients who had low vision, there was a low vision intervention with the team members discussed above. It was kind of a little ambiguous in the study, but they looked at reading speed, reading accuracy, and reading fluency after the intervention, and all 3 subjects improved on these metrics. And then finally, visual acuity with low vision devices. So this study looked at providing both distance visual devices as well as near vision devices. And overall, patients had significant improvement in both near and distance visual acuity when they used these devices. So obviously some promising data here. Let's just quickly review the devices. You probably have all remember these from boards or just training in general, but the magnifying spectacles for near work, as well as your stand and hand magnifiers. These are often what our children use for near work. And then for distance work, you have your telescopes, which can be mounted and worn, or your handheld telescopes. You have video magnifiers. So this is a handheld video magnifier versus a stand magnifier. They magnify and whatever you project on the screen here, and you can change the power and the contrast and different things like that. A little bit of new technology. This is called the OR cam. It's a camera that's mounted on the glasses. It uses artificial intelligence to kind of scan, and then it talks to the patient. So it can do things like read text, recognize faces, identify products, and more. And the Iris Vision is kind of the mounted version of the previous device. You can't walk around with this, but essentially if you wanted to sit and watch television, it provides 70-degree field of view, and this would kind of help describe the TV. It can read to you, and there's a scene mode as well. And then lastly, we're going to talk about some exciting apps. I've actually learned about these from my patients. Here are 3 apps here. They essentially do the same thing, where you project your live view camera on these apps, and it uses artificial intelligence to identify important items in the environment, such as exit signs, bathrooms, furniture, or objects nearby. These are very helpful devices, or helpful apps rather, that pair people who don't see very well with sighted volunteers, and essentially use live video chat or photos to communicate with volunteers on the other end. One of our patients said that she dropped something in her laundry when she was at college, and she used this app to talk to someone on the other end who could help coach her to find the object that she dropped in the pile of clothes. And then this is very helpful. This is a cash reader, so it just tells individuals who cannot see very well how much money that they have. And then these are some low vision apps. These are just good for visual targets and leisure, called Big Bang Pictures or Big Bang Patterns or Tap Tap See. So some of it's just for leisure for these kids. So in conclusion, there's some promising evidence for low vision rehabilitation strategies, some promising technologies for our patients, but obviously we would benefit from a lot more research in this area. And then I'd also like to thank my colleague, Anna Perlmutter, who helped me a lot with this. She's an occupational therapist with this talk, so I appreciate that.
Thank you so much, Margaret. Awesome talk with awesome resources. Our final speaker tonight is going to be Dr. Susan Cardin. Susan is an associate professor in the Department of Pediatrics at the University of Melbourne. She's a pediatric ophthalmologist at the Royal Children's Hospital and Monash Children's Hospital and the Royal Victorian Eye and Ear Hospital in Melbourne, Australia. Dr. Cardin is also head of education, the Education Vision Assessment Clinic at the Royal Victorian Eye and Ear Hospital in conjunction with the State Education Department. Dr. Cardin has proven to be an expert in her field, and she will be giving her unique perspective of telehealth and low vision. Thank you so much for joining us.
I'm sorry, Lauren. I'm just trying to find this to share. And has that come up?
I don't think it's your talk.
Sharing. hang on, I apologize. And show. And sorry, I've just done something silly. Oh. Why won't that share? Zoom.
Kate, can you help us with this possibly?
Sorry, I'm just on the laptop and I'll just.
You are
share.
sharing your screen, it's just not the
Susan, your
top.
screen is sharing, but it is showing your Zoom. So you
Okay.
want to choose the location where you have the presentation. So if it's a PowerPoint
Okay.
and it's at the bottom of your screen, you're going to want to pick that.
So I'm really sorry. It just won't let me. How do I go? It's on my desktop.
Okay, so the X in the corner of that screen, you're going to click X. My guess is your presentation's probably behind. So if you click X,
X
close.
on where about? Oh my gosh, this is not fair. What's happened? So X on.
If you close out that window, so go straight up from the scroll bar to the X to close out that window. You're at the square, close out the X. Now select your share screen at the bottom of your screen on Zoom. And it should allow you to choose what you want to share.
So has that come up now? PowerPoint.
Not
There?
yet.
Oh, I'm so sorry. Why?
Susan, I will place my email address in the private chat. If you email me the talk, you can begin your talk, and I will try to post the slides as soon as I receive them in my inbox.
Oh, or Lauren, have you got them there?
I don't have it right here, but can you email it to Kate?
I've got the Zoom. Okay. Okay, that's great. So I've just got Zoom. Why didn't I do this? So yeah,
Go ahead and
I've
email your
just-
talk to Kate. And then Jenny, can we should we use this time to answer a question? One of the two of the questions that came up?
Yes, okay, yes, you can start with that, Dr. Dida, go ahead.
Okay, great. So yeah, Susan, email your talk to Kate, and I'll ask the question. So one of the first questions that came up, Dr. Legge, who is in Nebraska, I believe, this would be for Linda and possibly Melinda. He wanted to know more about the eye tracker visual field device, in particular, Linda, that was posed to you.
Yeah, I did. Let me see if I've got, is the picture up?
Yes, I can see your talk.
Okay, so this is something that we developed. Now, this is just a Surface tablet, and down below here it has a plug-in. You just plug it into the device. It's a Tobii Dynavox. I mean, that's the one that we could get very inexpensively. It's about $200, and you plug it in, and it monitors the gaze of the patient. So we have the patient sit in a chair typically, and they play a video game. And then we have some software. We use free software, low-cost software, and it actually records where the hits are of the games that they're playing. My teachers for the vision impaired do this. They're experts in it. So if anybody wants to look at our protocol or talk to, I can give you the information, but we do a lot of this now. The teachers, this is actually my husband here who was working with us in Guatemala. He knows a lot about sensors and technology. So he was doing all of the eye gaze down there. But we use it to try and get an idea of how the child's using their vision. It's not evidence-based. The research is not there to say we're looking at how does that child see, and we could do it by having them play games with their eyes and looking at the visual field that they have. And it's just amazing what we find. But my teachers are really the experts in the area. And Skip, if you want to come down sometime, or I can have my TVIs. They're really the experts on the protocols and how to do this. They go into the classroom now so they can do this eye gaze in more of a typical environment. And it's a snapshot, and it's trying to help us understand how the child sees.
Great, thank you.
Oops, let me get out.
Susan, were you able to, or Kate, are we able to get her talk up yet? If not, Jenny, I think we'll take the next question.
Just not email me the talk yet, so go ahead with the next question.
Okay, thank you. We had a question also from Dr. Richard Legge from the Midwest here in the US to Dr. Chang about the source of the genetic panel and for the CVI children. And Dr. Chang, could you answer that for us?
Sure. So we don't actually have a panel that's specific for CVI. We do have like an ocular focused exome panel here at CHLA, which is an internal exome panel. So they get whole exome sequencing, and then they just look at specific genes. But that's more for like retinal dystrophies and hereditary optic neuropathies. For CVI, because it's so heterogeneous, it really depends on what other things you find, like their dysmorphic features, their seizures, hypotonia, things like that. So I work closely with medical genetics as well as pediatric neurology to determine what the type of genetic testing makes the most sense.
Great, thank you. We had another question. I'll kind of lump these together. Melinda, CVI is definitely a hot topic. So one question was about prognostication for kids. Are there any presentations that help you prognosticate how the children are going to do? And there's another question that's kind of more general, but CVI, discussing it in either isolation or in the sense of the spectrum of autism and global developmental delays. How do you address those? Are there any sensory components that kind of help separate these two entities or help a prognostication for these kids?
So in terms of prognostication, the literature has been really mixed. I mean, some studies show that based on MRI, what part of the brain is involved, like for example, involvement in the optic radiations might be a poor prognostic sign, but others show the opposite, that involvement in the optic radiations was a better prognostic sign. And similarly, in terms of the age of onset, some studies found that earlier age of presentation was associated with better outcome, whereas others found that earlier age of onset was associated with worse outcomes. So I think it's really hard to tell. The only consistent thing really seems to be like whether control the underlying neurologic disorder occurs, and that seems to be associated with improved vision ability to improve over time. So I'm really hopeful that some of the new technologies that we are working on may help us better understand prognostication, but I don't think we're quite there yet. Oh, the other thing is VEP. There were some earlier studies that showed VEP might be prognostic, but basically the only thing that they found was whether the VEP was recordable or not, was associated with whether their vision could improve or not. So if you had a completely unrecordable VEP, then it was unlikely that the vision would improve. And then the other question about CVI and sort of autism spectrum, very complicated issue, and some of it comes back to how you define CVI. So in kids, if you're defining CVI based on decreased visual acuity or decreased visual fields, that's a lot more clear cut. But if it's more of the higher processing visual deficits, it's very difficult to tell if they're not paying attention to things visually because of, well, attention issues or sensory issues. So I don't think right now there's a great way to really sort that out. But I think the first step is a very complete neuro-ophthalmologic exam, as well as gold standard ADOS testing by a neuropsychologist to help determine if they really have autism. And interestingly, there has been some work done here at CHLA to try to adapt the ADOS for kids who have visual impairment, because some of the signs of autism, as you know, are visual.
And then I need my talk behind.
So for example, like whether or not they make eye contact, that might be due to autism versus visual impairment. So a neuropsychologist may be able to help you tease that out.
May
Thank
I
you
add
so much.
something too? May I add something?
Sure.
I think that we also need to be aware of the medications that these children may be on, because some of them are on medications that are going to interfere with their accommodation. And that can also affect how they're going to respond visually. Just another point.
So Jenny, I know we're getting close to the time of the end of this webinar. I know Susan just got her talk up. What should we do at this point?
So I wanted to ask then, Kate in the APO script would be able to, even though it's beyond the time allotment, would be able to do the talk?
Just for a
Yes,
sec.
we can continue. It will not shut off until we end.
Oh, perfect. So yes, let's proceed. Thank you,
Okay.
Dr. Cardin.
Great.
Stay there, Dimitri, in case.
Go ahead, Susan.
Thanks.
Thank you so much. For anyone that wants to stay on, Susan's going to talk about telehealth and low vision. And thank you so much, Melinda, for your comments.
Thank you so much. And it's really great to have a webinar on low vision. And I've really enjoyed all the talks. It's just been wonderful. Now, I'm in Australia, so I acknowledge and pay respect to the Bunurong people of the Kulin Nation as the traditional owners and custodians of the waters and lands around where I speak. And I dearly thank our team in the Education Vision Assessment Clinic at the Royal Victorian Eye and Ear Hospital in Australia. So the airline and shipping industries have had decades of telehealth for medical emergencies, such as MedLink. Thus, while telehealth is not a new technique, to us as paediatric ophthalmologists, it has presented itself as a seismic shift in our consultation style to keep our patients and staff safe by distance. Due to that pandemic, we are now into our third year of telehealth. The learning curve has been tedious in many ways. For our patients with low vision, we continue to learn and modify how best to perform functional visual assessments via teleophthalmology. So prior to the pandemic, new hospitals were developing large telemedical capacities. And this is an example from a hospital I visited in Qiqihar in China in 2019 with a really large telemedical studio. Geographically isolated children across Australia have had access to School of the Air since 1951 with two-way radio broadcasts. And their motto has been relevant to us, which is parted but united. For children with low vision, functional visual assessments are important to perform, especially during the pandemic. 80% of classroom learning is visual. A significant impediment to learning is lack of access to information. If you can't see it, you can't access it. A functional visual assessment is important for students who are vision impaired so that appropriate skills, technology and classroom management, whether at school or virtually, can be organised. Telehealth can be helpful for a functional visual assessment so that the child with vision impairment is not left behind. In our paediatric low vision clinic, the most frequent causes of vision impairment are retinal dystrophies as the highest number, optic nerve pathology, albinism, infantile motor nystagmus, cortical vision impairment, retinopathy of prematurity, and congenital cataract-related low vision. It's really helpful to consider the hierarchy of skills for children with low vision, even for telehealth consultations. At the absolute top are orientation and mobility, as was mentioned earlier. And this is the most important skill because it is about safety, getting about school, crossing a road, and eventually getting to work. Organisational skills in life and education are fundamental. Social skills, such as forming relationships for success and happiness. Self-help skills, being able to troubleshoot and actually be able to tell their teachers what they need and answer questions about their impairment. Compensatory access skills, being able to access the curriculum. And then we come to cognitive and academic development. Academic success is important, but without the higher ranking skills, it may not lead to employment and a fulfilling life. Pre-telehealth consultation preparation is important. The telehealth consultations in our vision assessment clinic range from 30 to 45 minutes. The pre-telehealth consultation work is essential and time-consuming. Information about the child, both medical and other, is necessary with which to familiarise ourselves, or as said earlier, it's our homework. Where is the family situated for the telehealth consultation? Are they at home, at school, or even in the car near a hotspot? This may depend on the family's access to reasonable speed internet. Socioeconomically disadvantaged families need to be catered for. Some may not be equipped for or are unfamiliar or even uncomfortable with video conferencing technology, such as some parents I've had will not actually show their face on the video. An interpreter, if required, has to be online, and specialist vision teachers are on the conference. We also have a psychologist. Telehealth is exhausting, and it takes longer than face-to-face consultations. On screen, it is difficult to set the rules of engagement with the family. In the office, we all do this unconsciously. Years of learning have taught all of us to organise the consultation in our organised office. In face-to-face consultations, we glean crucial information about the vision impaired patient during every moment they are present. We watch the family enter the room, the interpersonal exchanges, the visual curiosity of the child, the ability of the child to ambulate, and so on. Our office spaces have been designed to facilitate the examinations. The screen does not. Many visual cues are lost on screen, such as eye contact, interpersonal distance, and gestures. The initial testing by an orthoptist or ophthalmic technician before our usual face-to-face consultation has not occurred. In other words, as paediatric ophthalmologists, we begin the virtual examination well behind in our understanding of the child compared to face-to-face exams. During the consultation itself, it's important to observe the lighting of the room where the family is. Is it too bright and glary with curtains open when the child we are assessing has, for instance, albinism? Or is it too dark for the child who may have a rod cone dystrophy? Carers may be trying to show the worst situation, whereas we often want to know the child's best potential. Visual acuity testing can be sent to the families beforehand, but generally it's the functional assessment that is the most important, and we tend to use the child's favourite books. This also lengthens their attention span. On the telehealth consultation, our specialist teachers ask the child to find letters or to read aloud from their books. Font size can be estimated. Observe neurobehavioural traits and adaptations on the screen. Is there an abnormal head posture? This might indicate a nystagmus null point. Or is there a visual field defect where there's a hemianopia causing a face turn? Maybe there's diplopia and a 6th nerve palsy and a face turn helping with that. There may be a head tilt. Overlooking might suggest a macular abnormality since infancy. Eccentric viewing, maybe there's a later onset macular abnormality. Holding books closely might be due to an uncorrected refractive error, such as myopia, or it may be for magnification. Searching movements might suggest a small field of vision. Using the index finger to guide reading on a page might signify a constricted field of vision or other issues. All of these are crucial to note and to carefully explain to the teachers why the child is doing it. And telehealth is quite helpful for this. You can observe ambulation in the home. Sure, it's familiar territory, but nevertheless, it's quite helpful. The child might trip over their sleeping dog, suggesting a field defect, poor attention, or worse vision than you had considered. There are many major disadvantages of telehealth in assessing functional vision. And if there's one technique that we miss more than anything else in teleophthalmology, it is retinoscopy. One of the most common avoidable causes of vision impairment is refractive error. Children with low vision due to an underlying ocular disease often have a significant ametropia, for which correction could improve their vision significantly. We miss visual field testing for the older child. We miss correlating fundal findings with function. The socioeconomically disadvantaged may have poor internet access. However, learning about this is helpful in the long term, as the extent of the disadvantage may not have been recognised previously. On reflection, teleophthalmology is now part of our toolkit for assessing children with vision impairment. Acknowledge its shortcomings and use its benefits. It is more difficult and time-consuming than a face-to-face consultation. Yes, we are parted, but we are united in our aim to keep children with low vision and their families supported in troubled times. Thank you.
Thank you so much, Susan. I'm so glad that you were able to get your talk loaded. It was excellent. Well, we did go over on the webinar tonight, but I think we had amazing speakers, amazing topics, and I truly thank everyone on the committee who volunteered to give these talks. You're experts and you're amazing in what you do to help our patients and our families. I think we have one final comment from Jenny.
Oh, yes. And thank you so much, Lauren, for doing an outstanding job as the moderator for this webinar. And thank you for all of the participants in this great membership of APOS that participated tonight, and is truly international group of panelists and experts. And Lauren, thank you for your leadership in being chair of this pediatric low vision committee for APOS, as well as this webinar. And as we had mentioned, we don't know when it'll be available, but all of this will be available on YouTube via our APOS website at a later time. And stay safe, everyone, and Happy New Year. Forgot to thank Kate and Christina and APOS. Thank you so much for making this webinar possible through the technical issues. Thank you so much, Kate and Christina.
Yes, thank you.